Hello, I'm Dr. Ward Dean, Medical Director for Vitamin Research Products. The first International Anti-Aging Conference, which was sponsored jointly by Vitamin Research and International Anti-Aging Systems, was held on June 17th and 18th, 2000 in Monte Carlo, Monaco. The conference attracted scientists, clinicians, and anti-aging enthusiasts from around the world. These tapes offer an opportunity to listen to the wealth of information that was presented. For those who were unable to attend the conference, it offers a hint of the experience that they missed. Please join me as I listen to one of the speakers at this breakthrough conference. I cordially invite you to join us at the next conference in Monaco next year, which promises to offer a similar roster of international specialists in anti-aging medicine.
Our next speaker graduated from the Loma Linda College of Medicine and has become one of the leading experts in allergies and environmental medicine. He was the past president of the American Academy of Environmental Medicine and has distinguished himself by being selected for the faculty of the American College of Advancement in Medicine, specializing in anti-aging workshops. A regular speaker at medical conferences across the United States, would you please welcome Dr. Richard Wilkinson.
Good morning. I wish to thank Mr. Reed, Mr. Watson, and the others who have organized this conference for the opportunity of speaking, of giving a lecture here. It is a privilege to speak to you about one of the older longevity treatments. To my way of thinking, it's foundational. I will attempt to briefly explain why, and then review the evaluation and treatment of thyroid disorders. It's easy to forget our history, and the history is something which gives us a perspective on the present and gives us a guide to our future. And it is easy in medicine, where changes are taking place so extremely rapidly in so many different fields, to forget those foundational studies, the foundational work that gives us a way of approaching our skills and our trade. The history of the thyroid gland is one which, geologically speaking, began only a split second ago. But from a medical perspective, it was eons ago. The ancient history of the thyroid begins in London in the 1870s with a physician by the name of Dr. Ord. The originations of serious thyroid research began with Dr. William Ord in London. He had a patient who he had followed for many years, who was a woman who was very active. She was in good health until she reached the age of 49, and he began to notice a very significant change in both her appearance and her demeanor. First of all, she started getting cold. Then other symptoms began to affect her. Her hands became weak and clumsy. She found that she couldn't work very well. She was chronically fatigued. Her mental faculties were decreased. She couldn't think as well as she had before. Her movements became slow and awkward. In fact, it got so that it would take her 2 hours just to get herself dressed in the morning. She fell asleep unless she was moving about. Her face became swollen and expressionless, and she died at age 60. And so autopsy was done. And as they looked at her at autopsy, what they discovered were several things. One, that the swelling of the skin and the connective tissue was different than that when people would die of renal failure, as an example. When people would die from renal failure, they could cut the skin and water would seep out. In this situation, they'd cut the skin. It looked like there was a lot of water there, but nothing would come out. The thyroid gland was completely replaced with fibrous tissue, and the entire arterial system was affected with serious atherosclerosis. So Dr. Ord wrote up this case, and it was his feeling that probably the systemic effects and symptoms were as a result of the thyroid being displaced with fibrous tissue. He believed that the lack of the thyroid was the cause of the severe systemic atherosclerosis. He asked a chemist to evaluate the thick substance that was in the skin holding onto the water, and it was defined as being mucin. Hence we have the name myxedema, where mix is the word for mucin, although currently it is referred to as mucopolysaccharides. The work of Dr. Ord created a great interest in further exploring what the effect of the thyroid gland might be on the body. And there was a commission, a royal commission, that was established to begin exploring the function of the thyroid gland, and this went on over several years. There's some fascinating history there, but just to give you a brief overview of some of that work. Sir Victor Horsley removed the thyroid gland from monkeys, swine, sheep, and donkeys, and all of them developed this mucinous swelling, this edematous state that they had seen in a patient of Dr. Ord's. Now, somewhat parallel in time, Dr. Bill Roth in Vienna had taken up what another physician had shortly before that developed, which was a safe way of removing thyroid glands. I don't know how many of you in this day and age have ever had the opportunity of seeing the large goiters which are still present in some parts of the world, such as Africa in particular. I've seen a number of them there. But these large goiters would create not only cosmetic effects, but also symptomatic effects. And so there was a lot of work done by the surgeons trying to develop ways of removing the thyroid. What Dr. Bill Roth found after developing a way of doing a safe thyroidectomy was that his patients would soon thereafter die of this hard swelling of the tissue, or the myxedema. One of the things that was particularly interesting in Austria where he worked was that there was a law mandating autopsies on every patient who died in the hospital. And so there was a wealth of information in Austria because of some of this autopsy work. What they found is that in all of these patients for whom he had done thyroidectomies, there was severe systemic atherosclerosis. Now, Bill Roth, as well as the London group, was quite interested in the effect of the thyroid, and so he had one of his students begin working on what the effect of the thyroid might be. Von Eilsberg, in 1895, did something similar to what Dr. Horsley did in London, and what he did was to remove the thyroid from sheep and goats, and significant because we have here vegetarian animals, and when he would do that, these animals as well developed systemic atherosclerosis. A couple of other professors by the name of Pick and Pineless repeated the work of Eilsberg. However, he found that if after taking out the thyroid, he would replace thyroid by giving thyroid desiccated, these animals would have the atherosclerosis prevented. This was some very, to us today at least, tantalizing information. However, at that time, it was not yet a significant, myocardial infarction in humans was not yet a significant issue, or any other manifestation of atherosclerosis in humans, and so this became something of a side note in history and was to some degree lost sight of. During World War I, Dr. Zondeck, a German physician, found that many of his patients, many soldiers, would have these enlarged hearts that wouldn't work as they ought to. These often became bedridden and weak, and he found that if he would give them a bit of thyroid, these people that were in congestive heart failure often would have a restoration of cardiac function and were able to return to normal active life. He wrote a book in 1944 published by Williams and Wilkin on the endocrine system, and one of the things that he pointed out was that perhaps one of the best ways of diagnosing low thyroid function, and this may still stand true today, is when there is low voltage on the EKG. This is certainly something that is highly suggestive of low thyroid function. Moving forward into the 1930s in the United States, we have Dr. Herxthal at the Leahy Clinic in Boston. Dr. Herxthal worked with many patients who would come into the clinic where there would be thyroidectomies done, particularly for hyperthyroid cases. He was involved in observing and following these patients both before and after their thyroidectomies. And what he noticed was that when patients would come into the clinic with hyperthyroidism, these patients routinely would have low levels of cholesterol. He observed that if too much thyroid was removed, and by this time the thyroidectomies which were done were rarely total thyroidectomies, he found that if too much thyroid was removed at the time of surgery, these patients would oftentimes become hypercholesterolemic. And so he, because of his work over a period of time, suggested that an elevated cholesterol level was virtually pathognomonic for hypothyroidism. He argued that unless there was some clear other evidence for the hypercholesterolemia, such as liver failure or kidney failure, that one ought to assume that this patient probably was hypothyroid. And in fact, he suggested that elevated cholesterol was probably an indication for treatment with thyroid unless there was kidney failure. Looking briefly at the cholesterol hypothesis in terms of diet, this began with the work of Anichkov, a Russian physiologist, in 1913. He observed in doing some of his laboratory research that if rabbits, who as you know are vegans, were fed large amounts of cholesterol, the cholesterol levels would go up several 100%. It would become toxic to the rabbits, and they would become sick and die. He, interestingly, did not extrapolate to human beings. Similar studies were done by his team on rats, dogs, and humans, but did not get the same results. Following this work, Friedland, in 1933, who was a student of Anichkov, repeated the experiments of giving large amounts of cholesterol to rabbits. And he was able to prevent atherosclerotic heart disease by simultaneously treating the animals with thyroid. So he pointed out that thyroid clearly controls the lipids in the serum, including cholesterol, and he again was one who advocated the use of thyroid prophylactically in patients with elevated cholesterol levels. A few years later, Turner, wanting to explore the same thing, did the research in a similar way, only with an additional aspect. He found that the rabbits who developed high cholesterol and atherosclerotic disease with hyperingestion of cholesterol were rabbits that were low in thyroid function. So his conclusion after a number of experiments was that thyroid deficiency was the problem, not the cholesterol per se. Now, if we take that information, we see that probably thyroid is an extremely important factor in longevity medicine because it is one of those things which helps not only to prevent hardening of the arteries, but as we'll see shortly, has numerous other effects in the human body, and many of these are often overlooked in the ways in which we commonly look at the thyroid gland. Now, just to run through a few of these, one of the things that the thyroid does is it increases the metabolism. It increases the oxygenation of the tissue. It has a strong effect on the heart, increasing not only its speed of action, but the strength of action. This then gives one some information as to dosing. If a person becomes hyperthyroid, one of the things that you should see is an increased rate of heartbeat, and thus it can be a guide as to the appropriate dose. Energy is produced by the thyroid. For growth to take place, the thyroid must be functioning. Heat production, thus we see people commonly who are cold are in need of thyroid, although one must not be blinded to the fact that sometimes people who are hypothyroid will be heat sensitive as well. It improves the blood circulation. It increases 2,3-DPG, which moves the oxygen dissociation curve off to the right, which means it's easier for oxygen to be distributed to the tissue. It improves immunity. It helps the body to get rid of waste products. It stimulates gut motility. We see here one of the signs or symptoms that a person can complain of if they are hypothyroid. And again, as we're going to talk about in a bit, one of the ways of picking up whether or not a person might be hypothyroid. It increases protein synthesis. It improves the neuromuscular function so that the speed of muscle contraction and relaxation is improved. Muscles work better. They contract faster and they relax faster. One of the practical effects of this is that one can check the Achilles reflex in particular, and in hypothyroidism that will be slow. If you do that routinely on your patients, you'll be able to see clearly that some people have a remarkably slow Achilles tendon reflex. We've already mentioned the lipid effects. It increases the oxygen consumption. One of the things that Dr. Dean spoke of here is the insulin sensitivity or lack of sensitivity. One of the things which thyroid does is it increases the entry of amino acids and sugars into the cell, which is then something related to Syndrome X, and one will find that diabetes will oftentimes be stabilized or benefited by supplementation with thyroid. Again, Dr. Dean spoke of the mitochondria. One of the things that thyroid does is it increases the ATP synthesis in the mitochondria in at least two different ways. One, it increases the cristae, which are the things upon which the ATP is generated, as well as stimulating greater production of ATP. Now, in our mind's eye, as we begin to talk about this further, it's important to be clear that there is not hard and fast this or that or the other, but rather there is this flux, this gradation between hyperthyroidism, where we have grossly hyperthyroid patients who are having a very significantly difficult time, to the hypothyroid patients, the grossly hypothyroid patients, which again are having serious times. But there is a whole group in between the clearly hyperthyroid and the clearly hypothyroid that are not quite so easily put into categories. In my opinion, the euthyroid state exists when lab tests are normal and the patient is clinically healthy or has no signs of hypothyroidism. Again, I appreciated what Dr. Dean had to say because this is helpful information as we work through in our mind's eye how we look at the thyroid function. We don't have just a thyroid gland working. We have a system that is working, which is dependent upon the proper function of the hypothalamus, of the pituitary, of the thyroid gland itself, of the carrying mechanisms to disperse the thyroid to the tissue, the ability of the thyroid to get into the cell itself, the ability of the cell to convert the T4, the inactive form, relatively speaking, into the more active form of T3. All of those systems must be working properly in order for there to be the normal thyroid function. If any of those is malfunctioning, a person can be in a clinically hypothyroid state. We'll get into this in other aspects in a bit, but if you give patients or animals T4 alone as an example, many of these animals will show low levels of the active form of T3 if you look at the liver, if you look at the kidney, if you look at other body tissues. This implies that sometimes the reason a person may be hypothyroid is not that there isn't an adequate supply of the material itself, but there is an inadequate supply of the materials which help it to convert into the active form of T3, or there is an adequate supply into the cell of the T3. So when we look at serum levels only, we're looking at a very small picture of what is going on. Now again, coming back to Dr. Dean's slides that he used earlier, the hypothalamus communicates with the pituitary, which then communicates with the thyroid. If we have the hypothalamus which is not working, we have what is referred to as tertiary hypothyroidism. If the pituitary is not working, then we have secondary hypothyroidism. And just to look at these for a minute, the tertiary hypothyroidism can occur for many different reasons: vascular disease, atherosclerotic disease to the vessels of the brain, infections, tumors, and so forth. A person can have secondary or pituitary hypothyroidism caused by many things. Tumors of the pituitary, one of the common ones is Sheehan syndrome, a postpartum necrosis of the pituitary, which is oftentimes overlooked. There can be a partial Sheehan's, if you will. So there are many reasons why the pituitary may not function. Now, what you need to keep clear with the diagnosis of hypothyroidism is that if a person has tertiary or secondary hypothyroidism, then obviously the person may well have a normal TSH, because there isn't going to be the push for the pituitary to put out TSH, or the pituitary will not be able to put out TSH, and consequently we will have normal or even low TSH when a person may be hypothyroid. I hope that's clear. This is such an important thing. If the hypothalamus isn't working or if the pituitary isn't working, then we're not going to get the production of TSH. And the simplistic way in which thyroid is often looked at, namely what is the TSH level, is going to totally miss people who are hypothyroid because of hypothalamic or pituitary dysfunction. We then have the primary hypothyroidism, which again, if the thyroid itself is not working. If we have failure of T4 to T3 conversion, if we have hormone transport problems, if we have peripheral hormone resistance, which is very much like insulin resistance, or if we have reverse T3. Reverse T3 is an inactive form of thyroid, and yet it can get into the receptors and can create blocks so that the active forms are unable to do their work. Now, from a practical standpoint, as patients come into your clinic and you sit down and you begin looking at them, what are some of the factors that you need to be clear might be things that would kind of suggest that thyroid should be looked at? One study showed that 7 or 8 times the risk in females compared to males. As we age, there is an increasing incidence of hypothyroidism. If people have thyroid antibodies, that is commonly associated with hypothyroidism. If there is a personal history of diabetes or other endocrinopathy, there are certain medications, such as beta blockers, dilantin, lithium, which can affect the thyroid. If a person is hypercholesterolemic, and if there is a family history of thyroid problems. There was a study put out by the University of Colorado Medical School in which they said that based solely on TSH, about 10% of people in the United States are low in thyroid function, with 20% of older women. When you consider other factors such as the history, the physical exam, and basal body temperatures, perhaps we see a hypothyroid incidence of 40% or more, which I believe was the number that Dr. Dean had used. In the chronically ill, many clinicians believe that it probably is at least 40%, if not greater. In order for a physician to see hypothyroidism, you have to kind of be immersed in it to some degree. You have to kind of have a feel and a sense of what you're looking for. I'll get to that again in just a minute here. The University of Colorado, in a great monograph, stated as follows: the symptoms associated with mild thyroid failure may not be apparent to the clinician, hence the value of the TSH assay. To my mind, that's an interesting observation and brings me to a point where I'd like to read a little bit from an author who is one of the folks that I've come to appreciate a great deal. His name is Dr. Bernard Lone. He's a cardiologist in Boston. He's been a professor at Harvard for many years. He wrote a book called The Lost Art of Healing. And in his book, he talks a great deal about how we have become so mechanical that we fail to look and listen to patients. And in trying to develop his argument of the importance of actually listening to the patient, of actually looking at the patient and feeling the patient, he tells the story of his own teacher, who is Dr. Levin. I don't really like to read much, and this isn't very long, but in order to get the sense of what he says, I think it would help if I read just a little bit here. During these many years, Dr. Lone says, my admiration for Dr. Levin's prodigious skill as a clinician grew. He believed that the bulk of relevant information could be obtained from a properly gathered history and a meticulously executed physical examination. He taught that a battery of tests must not replace a mind willing to think, yet he glorified in scientific advances. Following on the same theme, a sentence a couple pages later, he says, Dr. Levin hinted that frequent reliance on a so-called workup, engaging the heavy medical artillery of his day, such as X-ray or cardiac fluoroscopy and so forth, is a testimony to a lack of clinical skill. I thought that was very interesting. It was, again, as he says, goes on to point out, the physician, the good physician, should be able to have a good idea of what is really going on with the patient, and some of these tests would then become confirmatory rather than necessarily diagnostic, at least in the mind of the treating physician. And the last thing that I would like to read, because it relates directly to thyroid, is something that kind of relates to, my wife and I were in Paris earlier in this week. We decided to make a little trip of it. And so one of the treats was to stop by and give our greetings to the Mona Lisa. And there's a reference here to the Mona Lisa and why she has the universal appeal that she does, at least from Dr. Levin's standpoint. Dr. Levin was impressed with the brightness and quickness of hyperthyroid patients, at least mildly hyperthyroid. He admired them intensely and believed that the condition protected them against coronary artery disease. Now, he was a cardiologist. He obviously was aware of some of the research that had been done up until his time. I later learned when he became my patient that he, Dr. Levin, had taken 3 grains of thyroid daily for more than 30 years. He maintained that those with increased thyroid function had bright, sparkling eyes and appeared to be interesting people because personality is largely conveyed through the eyes. Levin suggested that the universal fascination with the Mona Lisa stems from her being hyperthyroid. Now, whether that's true, who knows? We can't run back and do any tests, but at least it's an interesting supposition. My point here is that these symptoms of mild hypothyroidism may be unapparent, it says, to the physician. I believe that it's important for us to develop a sensitivity so that we are aware of the signs and the symptoms that a person who comes into us has that might be indicative of thyroid dysfunction. And I think this is particularly important. Those of us who are involved in this field of longevity medicine and so-called alternative medicine are people who, I think, more than any other, need to be practitioners in our own personal life of those things of which we speak and of which we teach. There's more than one reason. One of the reasons is because we become personally acquainted with the benefits of those approaches which we suggest. And certainly the best way of a person who is borderline hypothyroid and yet not clearly aware of it, the best way to become aware of what thyroid can do is to be on it yourself and to see the changes and benefits from it. So I suggest that it's important to do those things and experience those things and experiment with those things that are applicable to us. Now, why might a person be hypothyroid? There are many different factors. Perhaps one of the most important is the deficiency of, in particular, selenium and iodine. If there are hormone deficiencies of other hormones, that can certainly affect. There are excesses which block the T4 into T3 conversion, and thus we have practical hypothyroidism, such as certain toxic materials, in particular cadmium, lithium can as well. too much estradiol, and perimenopause certainly can be a time when women become functionally hypothyroid. And as I'm sure many of you are aware, at the perimenopause, estrogen levels actually can increase fairly substantially in some women, which may be partially causal for the manifestation of the symptoms of hypothyroidism. Stress with the catecholamines, again, cortisol stress, reverse T3, medications such as beta blockers, excessive alcohol. Probably mercury is a factor, and probably infected root canals or cavitations are factors in causing thyroid dysfunction. But when we come to making an actual diagnosis of the patient, one of the problems of our age is the slipshod way in which medicine is practiced, where there is total reliance upon the laboratory and very little credence given to what the patient says or what one actually sees when one looks at the patient and listens to the patient. There is a blind confidence in the laboratory leading to superficial histories and physical examinations. Not only does it help us sometimes miss the diagnosis, but it also leads to patients, they get tired of us as docs. Doctors don't listen to us. And one of the things that I think is good about most of the physicians that I tend to associate with is that they're unusual in that they do listen to what the patients say. For many doctors, the lab is the gold standard and often is the sole criteria for defining hypothyroidism. What is missed is the difference between what might be the optimal versus what is normal. And as you all know, there is the bell curve. The bell curve includes 95% of everybody. At the ends, we have the outliers. And as long as a person is technically within the 95% range, they are considered to be normal. But if we look at it in respect to, say, the IQ, a person with an IQ of 100 has the mean. A person with an IQ of 80 is normal, and an IQ of 120 is normal. There's probably little doubt among us that there is an advantage to the person who has an IQ of 120 compared to the person with 80, even though they are both normal. In a similar way, just because a thyroid hormone level in the blood is, quotes, normal, doesn't mean that it's optimal nor that it's ideal. Optimal values for many hormones probably is closer to or above the mean of a healthy 20 to 35-year-old. And we must remember biochemical individuality, and some people may simply need more than what other people need. Over the years, there have been many, many different laboratory tests devised for looking at the thyroid hormone and thyroid function. One of the first was considered the protein-bound iodine, and for some period of time, that was considered to be the diagnostic tool for hypothyroidism. Over time, it has fallen to the wastebasket of history. Nobody virtually does that test anymore. It's considered to be basically useless. Many other tests have come and gone, and today what is considered to be the gold standard is the TSH. I've already mentioned to you some of the problems with looking solely at the TSH. There are some other issues, and I believe there's going to be a handout passed out. On that handout, one of the things that I have included is a couple of graphs which show the TSH levels through a 24-hour period. And the differences in TSH levels at different times during the day really are quite dramatic. And one of the examples, a person can have a TSH that is low as a 1 and a TSH that is as high as a 5, the same person during one 24-hour period of time. That shows you the kind of variability that one gets by doing a TSH, and if you did it at a different time, you would get different information. If you have a patient take thyroid who is on replacement, if they take their thyroid in the morning, that can affect the TSH, bringing it down, and so you then do a blood test to see how they're doing. The TSH is low, and you think maybe I've got them on too much thyroid. You need to be aware that thyroid is not a steady state. It's a variable thing to a fairly high degree. There are many things that will affect the TSH: fasting, exhaustion, depression, anxiety, The oral T4, as I've mentioned, will lower TSH, diabetes, post-traumatic stress, and so forth. There are many reasons why the T3 and the T4 may not give us a good piece of information, and I've listed some of them here, but I'm going to move on. Now, if we ask the question, what are tests that we can do that will assess the metabolic impact of the thyroid hormone? What will tell you how it's actually working in the physical body? One of the things that can give you that information is the history. Another is the physical exam, and we'll review a few of the factors that will be clues here in just a minute. The basal metabolic rate, the basal body temperatures, the Achilles reflex, the EKG with bradycardia or low voltage, and sometimes certain enzymes such as the elevated CPK, SGOT, LDH, or elevated cholesterol can be indicators. In the patient history, there are factors that are important to listen for or to ask for. If a woman is over 40, your index of suspicion should be greatly elevated. For men over 65, anybody that says, I really feel cold all the time, at least think thyroid. Fatigue, just not feeling well, dysphoria, sleeping too much, slowness, melancholy, headaches, dry skin, hair loss, nails which are thin, weak, or brittle, swelling, and that can be almost anywhere, constipation, hypoglycemia, menstrual problems including PMS, amenorrhea, other problems of menstruation, infertility, miscarriages. A history of miscarriage should really greatly raise your suspicion for thyroid. Family history of hypothyroidism. When you do the physical exam, what are things that you want to be particularly aware of? How about the hair? When the hair has become very thin and they have few, they're losing hair, the hair is very dry. The sign of Hertog, this is something that Jacques Hertog talked about, and I think it was his grandfather, Eugene Hertog, who noticed that people who are hypothyroid tend to, this is certainly not universally so, but tend to have the outer third of their eyebrows missing. Suborbital edema. You see that swelling down underneath the eye. Fluid buildup in the ears, a thick tongue. When you look in the mouth, you see indentions along the tongue. It indicates there's probably swelling, and thyroid could certainly be a factor. The skin, which is rough, sandpapery, and flaky. The thyroid being enlarged, being nodular, or being really small. You can't feel anything at all. If the heart sounds are distant or irregular, if the liver is enlarged, not even markedly so, but you can feel it as it comes down on a deep breath. You can feel it, maybe a little sore. Nails, we've mentioned the slow Achilles reflex. A high percentage of people with red hair tend to be hypothyroid. Now, we usually think of hypothyroid people as being overweight, but according to some work that's been done on this, probably about 60% are overweight. Actually, 20% are probably underweight, and about 20% are of a normal weight. So just expecting a person to be obese is not necessarily going to be a perfect clue. The basal body temperature, if it's too low, it certainly can be a clue that a person is hypothyroid. Now, one of the things that is far too frequently looked at, and that is the issue of thyroiditis. In my opinion, every person who comes in as a chronic kind of case, chronic pain, chronic fatigue, chronic headaches, chronic gut problems, needs to be evaluated for thyroiditis, which is a very common problem. One of the reasons is that even if the TSH, free T4, free T3, and other thyroid blood work is normal, thyroiditis in itself is justification, at least in the States, for proceeding with treatment. From Harrison's textbook of medicine, in view of the frequency with which hypothyroidism is either present or eventually develops, treatment of thyroiditis with replacement doses of, they say levothyroxine, I'll talk about that later, is indicated. But you treat the thyroiditis. In Merck's manual, treatment of Hashimoto's thyroiditis requires lifelong replacement with thyroid hormone to correct and prevent hypothyroidism. What is the best form of thyroid to use? This has been a long debated issue. The first thing that was used to treat hypothyroidism was desiccated thyroid. Then it became possible to synthetically manufacture the T4 in the laboratory, and T4, because of especially some of the work of some of the drug companies, became the drug of choice for hypothyroidism, and currently is out of vogue to treat with a combination of T4 and T3, which is what desiccated thyroid is. Dr. Barnes, an old gentleman who did a great deal of very important work on the thyroid, who I met when he was an old man, very interesting fellow to meet and to talk to. But he did a great deal of work on this, and he was convinced that Armour Thyroid, the desiccated form, was far and away the superior way for most patients to be treated. My own experience is that most patients do better with some form of desiccated thyroid. Armour itself has gone through some changes in the last few years. It has been bought, the trade name Armour Thyroid has been purchased by different companies, and there are 4 or 5 different hands that it's gone through. And there have been some things added to it, most recently I believe titanium oxide, which some people tend to react to. And so there are other forms of desiccated thyroid which are on the market. But one of these forms is probably the best way, at least in my opinion. Again and again I see people who have been on T4 alone, they're not feeling well, they come, we put them on a desiccated thyroid, and they do much better. The principle is use what works best for a given patient. I do have some patients that do better when they take T4 alone. And so I think it's important to listen to the patient and do for them what is best for them. Even though this has been a debated issue for many years, it's interesting, the study that was done by these folks, I'm not good at my Italian, so I'm not quite sure how to pronounce the name, but this study was published last year in the New England Journal of Medicine. It was a very interesting study indicating that a combination of T4 and T3 was highly preferable to the use of T4 alone. They note in their article that 20% of the daily production of T3 is produced by the thyroid. Fully 80% of it is converted in the tissues, so T4 becomes converted out at the tissue sites. Most patients are treated only with T4, and some of these patients do not do entirely well. They don't feel good, or at least nearly as well as they think they should on replacement thyroid. So these folks did a study to look at treatment with T4 only versus with treatment with T4 and T3. What they did was they took whatever dose the patient was on of T4, they subtracted 50 micrograms from the dose, and they substituted it with 12.5 micrograms of T3. What they found is that these people performed better on standard neuropsychological tasks, and their psychological state improved. And nobody, this is interesting, nobody did better with T4 alone. Not everybody did better with the combination, but nobody did better with T4 alone, and many did better with T4 and T3. On the handout is a listing of some of the symptoms that were evaluated, and in case you don't have them, I'm just going to read through some of those that were very significantly benefited by the group that was on the T4 plus T3. Sadness, confusion, fearfulness, irritability, tenseness, anger, tiredness. Physical symptoms that were improved included the feeling of being cold, blurred vision, nausea, sleepiness, Others were non-statistically significantly changed, but those were ones which were found to be significantly changed, benefited. Again, from the New England Journal study, it seems clear that treatment with T4 plus T3 improved the quality of life for most patients. In depressed patients who have normal thyroid hormone concentrations, the addition of T3 to a standard antidepressant drug treatment can be beneficial. Actually, this was not part of that study, but there are other studies that have been done where they have shown that people who were on antidepressants, where they had normal thyroid blood levels, were given T3 alone without the typical being low in thyroid, at least as it's described using TSH. In most all of these patients significantly benefited by the addition of the T3. In other patients who were depressed on antidepressants and on thyroid hormone, these patients didn't have some of the T4 subtracted from their daily dose. They simply added some T3 to it, somewhere between 12.5 and 50 micrograms per day. And these people did far better in terms of the depression that they were experiencing. So there is now good evidence to support what many of us have done for years, namely using a combination of the T4 and T3. Again, the study concludes that in patients with hypothyroidism, partial substitution of T3 for T4 may have more salutary effects on the brain and perhaps other tissues than T4 alone, which basically is the argument for using desiccated thyroid, or some would prefer to use Synthroid and Cytomel or some other combination, but I think it's important to remember the combination is significant. How do you dose it? To put it very simply, in my opinion, one should start low and go slow. There is a test, it's called the coffee test, and it's a very simple test. If your patient says that when they have coffee in the morning, it makes it difficult for them to sleep that night, you want to start really low, probably 1/4 of a grain. If a person can drink 2 cups of coffee and go lay down and go to sleep at night, you could probably easily start with a grain of thyroid. A couple of cautions. One of them is, if a person has had a recent heart attack or has anginal types of problems, you want to start really low again and go slow. If a person does worse as you put them on thyroid, what you want to remember is that even in the PDR, there is a contraindication for the use of thyroid, and that is if the person's adrenals are not working or if they're hypoadrenal. In those patients where it looks like they really should have some thyroid, but they do worse, what you might want to do is look at their adrenal function, put them on some physiologic dose of cortisone, and you may find that they'll do much better that way. Dr. Barnes used certain criteria to tell whether a person has had enough thyroid. One is complete resolution of the signs and symptoms. Another is if the basal temperature is low and the patient has the symptoms that are still problematic, keep increasing the dose until one of the following things happens. There is a resolution of the symptoms and the signs. The basal body temperature gets up to about 98. The patient is up to 4 grains of thyroid. There are certainly exceptions to that, but you want to be careful if you're going above 4 grains of thyroid. If there are signs or symptoms of hyperthyroidism, such as the pulse rate is getting too high, the person is feeling hyper, they're anxious, they can't sleep at night, they're hot, you want to back down. An elevated free T3 or free T4 may be an indicator as well that you are overdosing. So even going to the standard medical literature, one of the questions is, should patients with even mild thyroid failure be treated? And the University of Colorado School of Medicine monograph really has some good materials, even though I would disagree with some of it. And one of the things that they do say is that there are three principal reasons for treating patients with mild thyroid failure. One, to avert progression of mild thyroid failure to overt hypothyroidism. To reduce elevated cholesterol levels, thereby reducing cardiovascular risk. And to reverse the effect of mild thyroid deficiency on many organ systems and relieve the subtle symptoms and signs caused by thyroid hormone deficiency, thus improving the patient's quality of life. In conclusion, I would just mention that for those that are practicing in the United States, the legal system is such that I think it's very important for you to be clear in your charting, because some of my colleagues have had difficulties with this. They treat based upon they're sure that the person has hypothyroidism, but when the authorities come in and take a look, what needs to be clear is that there is documentation in the chart that there is no sign of hyperthyroid. So you want to make note that there are no signs of hyperthyroidism, assuming that there are not. It is important for you to do blood work on a regular kind of basis. If there is any conflict with authorities, you can always come back and use that as information that you're following the patient carefully. It's not just a clinical following, or you're not really ignoring the patient. You really are paying attention, and I think it will stand you in good stead. With that, I think we'll conclude and we'll turn it back over to you. Thank you for your time and for your attention.